Okay, so 3 of us were giving chemo plus Bev. You were giving chemo plus EGF if you knew it, if you added it later on. 4, 6 cycles in, CT scan, nice response, pretty normal, minor response, symptoms gone, no cumulative toxicity other than the usual wear and tear. So, maintenance now, give some more. Where are you? So we Bev people, where are we? I might switch right away, I'll tell you.
It's a KRAS mutant. Let's be all open.
Okay, we'll all be Bev people. And it's a mutated patient and a tumor, and we're at 3 months, okay, and a decent response, CEA down, good performance status.
Well, I would usually at 3 months go a little bit longer if they haven't plateaued on their CAT scan. I mean, we tend to see that they get the biggest effect in the first 3 months, but people can often keep
Do you do
responding.
scans at 4, or it depends on the patient?
Usually every 2 months.
Every 2, yeah, I do 2 up
most
front.
oftenly.
Yeah.
But you know,
But you have to do that peer-to-peer for that, you know, because that 2 months sometimes is a little tight for them.
Yeah, so so I might be tempted to go a little bit longer, you know, 4 or 5 months, maybe 6 months. But at that point, I would definitely go over to fluoropyrimidine plus Bev maintenance.
Is that what you do?
Yes.
Yeah.
I would do the same. You know, I like to watch CEAs in my patients whose tumors make CEA, and I like to see it start to plateau at a lower level. If the patient has peritoneal disease, I worry about stopping treatment entirely. And so I like the notion of lightening the treatment up and making it easier to tolerate. And so I would likely go to a fluoropyrimidine plus Bev at some point between 3 and 6 months of treatment.
Magic 8 cycles, oxaliplatin, discontinue it in this metastatic setting, go with the 5 fluoropyrimidine Bev.
So is everybody using CAPE here, or are we using pump? You sending them home with a pump for their vacation?
Well, I have historically used the 5FU with a pump because I think the 3-week regimen with capecitabine, like 1,000 per meter squared twice a day, is really very difficult for most patients to tolerate. So I used to give 5FU. The Cairo-3 data where they give a lower dose, 650 twice a day per meter squared twice a day, continuously, so no break, is actually pretty user-friendly, and I've been using that some too.
It's the only way to go.
So I think that 2 days out of every 2 weeks of treatment is better than 3 weeks out of every 4 weeks of treatment. So I would rather have patients get the 48-hour infusion.
Have you ever carried a pump?
I have not carried a pump. Have you?
No.
Are you going to sentence me to carry a pump?
Well, I think we all should wrap
I used to
one
carry
around
a
our
really
necks.
big cell phone, though.
But it's important to evaluate the patient's benefits to out-of-pocket pays when it comes to oral
Yes, that's a good
chemotherapy. I'm not a big fan of oral, capecitabine, although in the older population, the Cape-Bev is intriguing for older patients, but I would use more the CAPE dose from the Cairo-3 than the
Okay,
full
back
dose.
to the value discussion. ASCO is proposing that they do bundled payments based on outcomes. So you get basically a wad of money, and you get to spend it to take care of your metastatic colon patient. What do you do with your Bev?
Well, so there's that interesting meta-analysis from Europe that suggests that Bev's a bad deal. That it really isn't cost effective.
And the economic analyses in the U.S. have pretty much tended to support it.
JCO 2 weeks ago.
Yeah.
Right. And so, I had a patient recently that didn't have insurance, railed against Obamacare rather than getting it. And, I told him, your FOLFOX will cost this much, your FOLFOX plus Bev will cost that much, and this is what you can expect from the incremental Bev. And he said, I ain't buying that.
Why would I buy that?
Right.
It is an incredibly different perspective when, as I like to put it, when you have to swipe your own credit card for it. You make a different decision.
I think though that, my problem with most of those analyses is that the metrics they use aren't really probably the best ones that you could come up with. And For example, the 966 trial that showed a minimal benefit of BEV, a lot of them use that, and I think that trial was kind of flawed in its design and even more flawed in how it was carried out. So it didn't achieve the optimal use of BEV. And as support for that point of view, I would look at the 80405 data, which really show, like, people have a median survival now of 30 months. It's huge, and I think it's because in real life people are using these drugs a lot better, and it translates into overall survival, which is really not reflected very well in all those economic analyses. So I'm in terms of value, I think we don't have all the right data when these are done.
Quick question, quick answer. So same case, but now we have the molecular profile. RAS wild type, BRAF mutant.
I'm intrigued by the folfoxiri BEV for that subgroup of population, and this is one of the cases where I may adopt the kitchen sink.
Yeah.
I would agree with that.
Yeah, I've been doing that for the last couple of years, and I think that it's really has the best benefit is to go with folfoxiri. I mean, there's something a little bit quantitatively different by adding in the topo-1 inhibitor to Folfox. And even, in the original 9741 trial, which Dr. Goldberg managed to present many times, and actually presented good data many times, not like the abstracts we're seeing now where every study has 20 sub-abstracts, but in any case, there was an IROX arm, which was irinotecan plus oxaliplatin. So the combination of a topo-1 inhibitor with a platinum drug is different biologically than a fluoropyrimidine with a platinum drug. And I use even that regimen sometimes kind of as when I go back to treat people and see that they respond very well to that combination.
So my notion is that if you don't think you're going to get 3 lines of therapy, then
That's
you
right.
want to be very intensive with your first line.
Spend them, yeah. New case.